Well, hello everybody. Welcome to the Guy's and St Thomas's Hospital's showcase event for the month of July. We're delighted to welcome some really distinguished guests today, really homing in on simulating success. And I love the title. Oh, this could only be from a hospital environment, integrating human factors for enhanced patient safety. I'd have written it differently, but that's fine. We've got a good audience today. We're really looking forward to getting to it. For those of you that don't know me, my name is John Wilks. I have the privilege of being Chief Executive of the Institute of Health and Social Care Management, and Guy's and St Thomas's is our London regional hub. I'm supported today by the one and only, the fabulous Charlotte Joseph. But first, cab off the rank today is Cindy Sethi, and Cindy's going to be talking about Patient Safety Incident Response Framework. I did see the acronym earlier, but just decided to say the whole thing because PSIRF doesn't sound terribly kind of short and snappy. But Cindy, I'm going to hand on to you. We will have Q&A at the end when Cindy has finished. So if you'd be patient enough until then, if you don't understand something you'd like clarification, and I'm sure Cindy will be delighted to answer at that point. Cindy, your slides are already decked, so over to you. Thank you.
Thank you. And thanks, John, and thanks the team for asking me to speak today. So no further ado, let's get cracking. Okay, so we're going to talk about patient safety. We're integrating human factors, we're integrating simulation, and I'm really going to set the scene with how our new patient safety strategy and framework support that thinking and the switch to being a learning organization. So this is a recent analysis, or meta-analysis rather, from the BMJ. Around 5% of patients can expect to experience preventable harm when under medical care. And we'll all know, those of us working in healthcare organisations, that many of these incidents could have been avoided if lessons from previous incidents had been learned, and often they're systems failures that are repeated. And getting this right it's estimated, could save almost 1,000 extra lives and 100 million a year in care costs. There's also the potential to reduce claims provision by around $750 million per year by 2025. So this is really showing you the link between improving quality and the cost effectiveness of improving pathways, improving services that is oftentimes linked. So there are some concepts that I just wanted to highlight to you that are really key to the strategy and the framework. And one is around a just and learning culture. So ensuring that the culture that we're embedding is that of fairness, of justice, of learning, and people often say, well, if we do that, who's going to be accountable for their actions? But there is that one does take responsibility for actions. However, it isn't about seeking blame. It isn't punitive. We have different processes for that. If we want to, if a complaint needs to be made, we have a complaints process, but this process is really about understanding the science and application of human factors and learning about those issues such as design of systems and processes, equipment, environmental factors that really impact our behaviour and performance within a work system. The other concept I just wanted to highlight is this safety 1 versus safety 2. So this is a framework that's been advocated by Erik Holnagel. He's a professor of patient safety science from Norway. And what you can see here is that, well, what safety 1 is that it's around when things go wrong. So it presumes that things go wrong because of identifiable failures or malfunctions of specific components, be that technology, equipment, generally humans, and that humans are really seen as a liability in a safety one system. And actually, up until now, much of what we've been talking about within patient safety, our serious incident framework, the fact that we collect data on when things go wrong, really focuses on when we've had an unintended or unwanted outcome. But what you can see from the bell-shaped curve is actually 95% from the meta-analysis, 95% of the time things go right. Now, they may go right just about, they may go just as planned, or a lot of the time they go right really well, and we're delivering really great service and great outcomes for our patients. So what can we learn about that 95% of the time when things are going right? And that's the switch. And it's much easier said than done, because our processes and pathways are really set up to learn from safety one. And that's a switch that we are making slowly. So examples are, we have the Datix, well, that we used to have a system called Datix. It's now other softwares are taking it, but where we collect data when things go wrong. We have a similar system to collect data when things go right. And from the evidence base, that really needs to be encouraged. So not only do we commend the person that the form is filled out about, who delivered the really great care, but we also commend the person who made the who filled out the form, who actually made the commendation in the first place. So our strategy, this was launched just as we were going into COVID lockdown, really, just a couple of months before then. It has been written or led, the lead writer was Aidan Fowler, who's a consultant physician at Imperial, but really written by various stakeholders, including patients, carers, and families. And it really has three components to it. So the first one is around understanding what's happening in patient safety in your organisation. And I'm going to talk a little bit about that. But essentially at Guy's and St Thomas's, we analysed 3.5 years of patient safety data. That includes incidents, complaints, coronal reports, patient feedback, and triangulated those data to give us a really clear picture of what's going on in our organisation. So once we have that insight, we then need to involve patients, carers, families, and staff in understanding those data, really nuancing it, understanding the impact it has on all of our stakeholders, and also then helping co-create improvements, so that we are really focusing on improving patient outcomes, improving our systems, and really embedding that safer culture. So I've mentioned it before, but Patient Safety Incident Response Framework, I will refer to it as PSIRF from now on. So PSIRF replaces our Serious Incident Framework. It is not an investigation framework, rather it supports the strategy, because it's all very well having a strategy, but strategies are nebulous. What we need is something that's going to help us implement that strategy, and that's what PSIRF aims to do. And it focuses on the system, adjust culture, and improvement. There are 4 tenets to it, so that really underpinning it is about compassionate engagement of those affected by patient safety incidents. So again, patients, carers, families, and staff, absolutely key that we remember that staff are the third victim. That we have a systems-based approach to learning from patient safety incidents, that we have flexibility. If we have an incident that's a fall, it used to be under the Serious Incident Framework, that meant that we had to do a serious incident investigation. We do not need to do that now. We are able to be proportionate in our response. And the framework and the response activities absolutely exclude activities that are portion blame. As I mentioned before, we have other systems by which we can do that. This is about learning, this is about investigating, this is about getting stakeholders together and leading to improvement. So I mentioned earlier that we had done a data analysis and we had found our 8 priority areas. And this is what all organizations have been asked to do. They've been asked to look at their patient safety data and come up with their priority areas of what we are going to improve. So for any acute trust, and indeed I would say any healthcare organizations, the safe administration of medications is always going to be up there. We have a lot of inpatients, so falls, pressure ulcers, failure to escalate the deteriorating patient is another theme. Delay, failure to act on diagnostic results. Our pathways, our administrative pathways are complicated. We have layer upon layer. Now we have a new electronic patient record, which makes some things better, some things a bit worse because it's new. And so that's a real focus for improvement. And always when you're doing surgery, then safe surgical procedures and pathways are really key. And for our pediatric colleagues, they really highlighted that extravasation was something that they wanted to focus on. So what we've done is we've looked at all our incidents and tried to identify contributory factors, so themes within those investigations that have been highlighted over the last 3.5 years. Because if we do that, those are the things we've already learned. And what that then means is that if we get a new fall, we will look at the contributory factors we've already identified. And if those contributory factors align with this current incident, well, that's great. We know about those factors and how they lead to falls. So what we'll do now, we'll have an incident review meeting, but what we are able to do now is say, right, well, we know about that. What we need to do is focus on improving it rather than have the very limited human resource that we have focus on another investigation that's going to identify the same contributory factors that we've had for the last few years. And what you can see here is that this is a schema from our policy, but it really does highlight that we have 3 types of incident that we can have a response to. So the trust priority incidents we've already discussed. So if it's a fall and a pressure ulcer, and we've already identified those contributory factors, we can park that and think, right, we're going to do some improvement work on that. However, if it's a fall that's completely new in an area that it's not really ever had a fall, there's definitely a new contributory factor here, we will do a learning response. And I'm going to talk about some of the learning responses that we can do within the framework. There are national or regulatory incidents such as child death, death of a person with learning disability, never events such as a misplaced NG tube. And if we have those sorts of events, then we do need to do a specific type of learning event, which is called a patient safety investigation. And then we have other incidents that don't fall in either of those categories. And again, we can get the stakeholders together, have our response meeting and work out the best learning response, if required, that we need to do for those incidents. So it's a much more sophisticated way of working out the best way that we're going to learn from that incident. And that's how the framework is really supporting this significant shift in safety culture. So we're not going to be just purely reactive and bureaucratic, but we can now start to be much more proactive in how we are improving patient safety. Now, I've said that I wanted to talk about some of the learning responses, but what's really important to understand about the 4 learning responses that I'm going to talk about is this framework. So this is the Systems Engineering Initiative for Patient Safety. It is a human factors based framework and it underpins all the learning responses that we use now within the PSIRF. So we've had an unintended or unexpected or unwanted patient safety or patient outcome. We then work back and we try and understand the work system by using this schema. So we divide it up into tools and technology, the internal so the organization itself, the internal environment, so where you're actually working, the tasks, so the what we're actually trying to do on a day-to-day basis. That's all encompassed by the external environment, so the political situation of regulators, and in the middle of all of this is people. So the communication, the interaction between tools and technology, and it's a flat hierarchy. So all of these domains are interacting with each other so that we have the processes that we work to that gave us the outcome. And this really helps us to try and understand work as done. And work as done changes with every shift probably, and changes through organizations, and may change when we have different tools, we've had a new EHR, or if we have our CQC visit. But it's really to try and understand how was work done on this in this particular moment that led to the processes that led to the unintended outcome for our patients. And hopefully this schema, again, this overview of the system, helps to characterize what we mean by each of those domains. So tools and technology, how usable is our new electronic health record? How accessible is it? How familiar are staff with it? The organization, so what were the rotas like? What were the schedules like? What's the workload like? Internal environment, was it really cold? Was it really hot? Is it really noisy? Is it a bit dark? Is it cluttered? With our tasks, how familiar are we with the tasks? How difficult is it? Is it something that we're very familiar with, or is there some ambiguity in the sequence of tasks? External environment, as we mentioned earlier, those societal or regulatory factors, and then how that all comes together to impact on the individuals, on the teams working together, and how work was actually done. And there's lots of proxies for work as done. It's really, again, it's a bit like it's much easier to work is done is a lovely package, but actually when you get lots of different stakeholders together to try and build up that picture, you might get work as prescribed. So a matron may tell you how work as prescribed is. An HCA on the ward might tell you how work is disclosed is, and then even our patient safety experts who are doing some of these investigations may tell you a little bit about work as analysed. And if we put all of these together, we might eventually get one version of the truth, which is work as done in that moment with that team. So I'm just going to talk a little bit about how the strategy, the framework, the SEEPS model then allows us to use these different tools for our learning responses. So there's 4 different tools that we use. There's the MDT review, the after action review, the swarm huddle, and the patient safety incident investigation. They're all slightly different, but based on that SEEPS framework. But I think it's really important just to highlight that for 3 of these responses, so all bar the patient safety incident investigation, the role of facilitation, the role of the facilitator in creating a safe and brave space where different stakeholders can speak up is absolutely key to understanding what happened on that day, i.e. the work as done on that day. So the MDT review is a really helpful response when you've got either historical patient safety incidents, or you might have a theme of patient safety incidents where you need different teams to come together. The time frame for completion is slightly different for each of the responses, and this is sort of a middling type review where it's around 3 months to complete it. You'll get different people together all in the same room, and what's really key here is that a lot of preparatory work needs to be done so that when you've got colleagues coming from different teams for about 2 or 3 hours, you really make the most of their time. And what's really important for all the responses is that you have really clear outcomes and outputs and how you're going to deliver improvements going forward. So the uses of the MDT are really when you've got historical or multiple incidents of a similar theme, but also where you've got complex patient pathways, and you really do need to get people together from different teams to really understand the pathway. The after action review, so that's another one of our learning responses that you aim to complete within a month. It's like work is done. It's really lovely and simple. You've got 4 questions. Yeah, I'll be done. You've got 4 questions that you would ask. These 4, it's a 2x2 matrix. It was developed by the American military. So when you've had either a very successful or unsuccessful event, what was expected to happen, what actually happened, what are the differences and why, and what's the learning? What do we need to do differently next time? So again, you can see here, when you have your stakeholders together, it's really important that the facilitator allows each of the stakeholders to speak so you can really understand work is done. Now, the after action review can be used when you have unexpected incidents, but can also be used to analyze common themes. And again, it's really important that the people that were directly involved in the incidents are invited. So for the MDT review, you may not have that. You may have people who understand the pathway or the process. But for the after action review, you need to have the people that were involved in the incident that can speak and tell you what happened. Now, the swarm huddle is really a new name for a hot debrief, but it's a hot debrief based on the SEEPS framework. So again, bringing in those human factors, allowing insights and reflections to happen as soon as possible after a patient safety incident, but you are going to focus on what those outcomes are and how you're going to drive forward improvement. Now, it can be tricky to free up people immediately, but what's really good about Swarm Huddle is that it prevents the buildup of fear and that gossip that goes around after a patient safety incident whilst you're waiting for an investigation. So it's really good at de-escalating a situation quickly. And then finally, the patient safety incident investigation. So this is really our most in-depth investigation, which is undertaken when you've had an incident or near miss that's indicated by either it was a regulatory event, it was a never event, or sometimes the teams decide that we need to do a patient safety incident investigation. This is different to the other 3 in that you don't bring all the stakeholders together. It is completed by a patient safety expert, and it can take up to 6 months to complete because you're interviewing people. And what's really key to all of these investigations, but particularly patient safety, is that you really get the views of the patients, their families, and carers involved in this. And it's not just at the end where you're presenting the report, but it's actually during the investigation. What did they want to know? And you can give them regular update as to how that investigation's going. So the opportunities are when we really want to identify types of new learning and improvement, and the engagement with patients and families is absolutely essential. Okay, thank you.
Thank you very much, Cindy. We are a bit pressed for time, but has anybody got an immediate question they might like to ask? Yeah, go ahead, Donna. Unmute and ask away.
When you say a just culture, what exactly do you mean by a just culture?
Okay, really good question, Donna. So there is a just culture guide. So a just culture is ensuring that we take a systems approach, that we don't apportion blame, and it's really aimed at line managers, but beyond that as well. And there's a guide, and the first question of that guide is essentially, was intentional harm was harm intentional in this case? And obviously we know that in 99% of the time it wasn't intentional. So then there are other questions that a line manager may ask to support that staff member, because we've talked about them being also affected. Nobody comes to work to do a bad job. And that's really what a just culture means, that it means that we are supporting that staff member through this process. Now, that doesn't mean that there may be some professional issues or other issues that we need to, performance issues that we need to address, but this is not the process that we are going to do that in. I'll find the link for the just culture and I can put it in the chat.
I was going to say that would be terrific, Cindy. Thank you very much.
Thank you very much. Thank you.
We're going to have to move on, I'm afraid. Cindy, one of the questions you might like to think about for the finale when we do a kind of a group Q&A thing is, from my perspective as an independent observer, it looks and sounds quite complicated. There's a lot of writing there. There's a lot of steps. There's a lot of pathways, processes, acronyms. I'm just wondering how you make this simple and appealing to staff and patients so they really buy into it. But that's something for us to think about. Please don't answer that question now. We'll be here till a week on Thursday. So I'm going to hand on. Thank you very much indeed, Cindy. We'll see you at the end when we do the round table. And Cindy's just put up the Just Guide, so thank you for that. I'm going to hand on now to Paul Gregg. Paul, you're going to talk about critical incidents specifically, and I'm going to hand straight over to you, if I may, in that regard.
Thank you very much. Yes, so Cindy has given us a very, very helpful understanding of the framework that we're operating in. And it's useful to have that conversation about just culture, because what I'd like to do now is take that framework and zoom right into the specifics of a critical incident. And over the next 20 minutes or so, we're going to work together to look at a real critical incident using publicly available information. So we're not disclosing any confidentialities in this. And we're going to look at what human factors insights actually add to our investigation, and perhaps importantly to our responses that we might make afterwards. Because we'll all be from very diverse professional backgrounds, the incident that we're going to investigate is not actually a clinical one. It's something that happened at the Oscars 7 years ago now. Some of you may remember the story that I'm about to share with you. It doesn't matter if this is the first time you've seen it though, because we're going to watch the event unfold more or less in real time. So we're going to take up the story with Warren Beatty and Faye Dunaway, about to hand out the award for Best Picture in 2017.
The Academy Award for Best Picture. La La Land.
Okay, so far so good. They've been handed an envelope, they've read out the name of a film, and the crowd is cheering for them. Well, let's fast forward just a few minutes ahead now and see what happens next.
Lost, by the way, but you know. Sorry, no, there's a mistake. Moonlight, you guys won Best Picture. This is not a joke. I'm afraid they read the wrong thing. This is not a joke. Moonlight has won Best Picture. Moonlight, Best Picture.
Oh dear. So we've had a fairly significant critical incident. Now, you might say, in the grand scheme of things, is it a big deal? Nobody's been hurt, nobody's died because of this, but clearly this was pretty embarrassing for the group involved in this. So the Oscars actually contract out the administration of the voting system and compiling the awards to PwC, the accountancy firm. This was not great publicity for them. This is one particular report that I found in the aftermath of it. And they use words like crazy, improbable, downright embarrassing. We've got to say it's an important event. The question that comes up in most of the media reports of this is this one in red. Who's really to blame? And this speaks to a lot of what Cindy was talking about. Now, you might not be surprised if I say this is not a question that I think is particularly helpful. I don't think it's a question that we should be asking. Certainly not those of us with a responsibility for investigating these incidents. But it may be something that's lurking in the background, certainly amongst press or if lawyers get involved. So let's think about that. Let's have that question in the back of our mind as I explain to you a little bit about what we've just witnessed. So here's a schematic of roughly what I imagine it looks like backstage. Warren Beatty and Faye Dunaway are the two actors that we've seen that were handed the card to read out. And the way that the system works is that there are two accountants from PwC, one on either side of the stage. We've got Martha Ruiz on our left as we're looking at it, Brian Cullinan on the right as we're looking at it. They've each got a briefcase that contains a complete set of all the envelopes with all of the awards in it. And it's done that way so that the actors making the presentations can go to either side of the stage to collect their envelope. It makes it easier for the stage director. On this occasion, Faye Dunaway and Warren Beatty go to Brian Cullinan's side of the stage. He accidentally gives them the wrong card. They go out on stage and the events unfold just as we've seen. What's supposed to happen is that as the actors go out on stage, the accountants cross-check each other. And if the actors go on to the opposite side, they take their duplicate card and they discard it. And this hasn't happened in this on this occurrence. So what's actually happened? If we rewind a couple of minutes, Leonardo DiCaprio has just handed out the award for Best Actress. He's awarded that to Emma Stone, who was in La La Land. He's come on from Martha Ruiz's side of the stage. Brian Cullinan is supposed to have discarded that duplicate card, but he's not. He's accidentally given that to Warren Beatty, who follow on. We know what's happening backstage at this point, actually, because it's captured in a number of images. We can see that Brian Cullinan here, he's the chap in the dinner jacket and the bow tie on the left-hand side. He's looking at his phone. What he's actually doing is putting this tweet out. And we can see Emma Stone's just come off stage from collecting her Oscar, and he's got distracted. He's been warned about this before, I believe. I think that he's been told not to engage with social media and to concentrate on the job, essentially. So if we're minded to ask ourselves who's to blame in this, well, it might not be looking very good for Brian Cullinan at the moment. But actually, there's so much more going on than just one person here. If we start just by looking at the environment that he's working in, aviators talk about the importance of something called a sterile cockpit. Sterile cockpit is a concept that says during certain critical phases of the flight, there should be no distractions going on and there should be no conversations that are not germane to the task that's being carried out. And if you look at the environment that he's working in, does that look in any way sterile? Well, no, it doesn't. There are distractions, noise, pressures from all sorts of different directions. If we think about things from a just culture point of view, one of the things that comes up in that guide that Cindy has shared with us is, would other people with similar training and backgrounds act differently in those circumstances? Well, I'm going to assert that no, probably not. If any one of us were in an environment surrounded by those celebrities with that privileged access, would we do anything different? I doubt it. I doubt it. The other important thing about our circumstances here are there are a few. I'm a human factors researcher as well as a clinician. I work with the University of Oxford, and I'm interested in the psychology that goes on behind a lot of this. There's a particular psychological vulnerability called search satisfaction that I think might have affected our team here. When you're in the middle of any task and you become distracted, it takes you a little bit of time to get back to where you were, to sort of rediscover your phase in the task. He's not been allowed that time. Warren Beatty and Faye Dunaway have just appeared. They have to be out on stage. There can't be a delay because it's going to mess up all of the schedules. So now he's faced with I need to hand out an envelope. Search satisfaction says that once you've found something that appears to satisfy your needs, you're not going to search any further through your stack. So what's topmost on his pile? It's the Best Actress card. It's the wrong card. Now, you might say that the critical incident happens at the point he hands out the wrong card. It doesn't. The critical incident doesn't actually happen until Faye Dunaway says the wrong film's name. So we've still got an opportunity to rescue the situation and avoid the incident if our team on stage recognise that they've been given the wrong information. Now, clearly that hasn't happened, and let's look at why that might be the case. I'm going to replay just a little bit of the video to give you a sense of what's going on at the moment. Now, I've muted it a little bit, so I'm going to talk over it, but I want you to look at Warren Beatty's body language here. Now, this does not look like a man who's confident in the information that he's been given. He looks uncomfortable and he looks uncertain. Now, Faye Dunaway misreads it. She thinks he's playing it for laughs. Right there, she says, "You're impossible." She doesn't understand why he's uncomfortable. I think that when he hands that card across to Faye Dunaway, he's asking her to cross-check it, but she doesn't understand that. So our team on stage have got different mental models. They've got different understandings about the situation that they're dealing with. So why don't they recognise that they've been given the wrong information? Because actually they've got the information they need to be able to recognise that they're about to make a mistake, because the envelope says Best Actress in a Leading Role. That's not what they've been told to hand out. But this is written on the front of the card, and envelopes are typically open from the back, so they might never have looked at it. Even if they have looked at it, that yellow on red, that's a very low contrast colour scheme. You can quantify it. That contrast ratio actually is 2.5 to 1. If you were making something to meet accessibility standards, it should be about 7 to 1. So it's very difficult to read, even under good lighting conditions. And if we think about what it's going to look like for them on stage, bright light shining in the face, going to be hard to read. But that's okay. If they don't recognise what's written on the outside of the envelope, the card still has Best Actress written on it. But not, I'm going to suggest, in a useful way. And this is where some of my psychology interest comes in, because humans tend to read things in predictable ways. So for us who might have English as a first language, we will typically start uppermost and leftmost on a screen like this. We'll progress to the right, we'll move down, progress to the right, and it forms a sort of Z pattern. We can use that knowledge to prioritise information on the card. If we think about what's most prominent on this, topmost, leftmost, is the word the Oscars. Well, actually, that's the least important information we can possibly put on the card, because let's be honest, if you walked up that red carpet in front of all those paparazzi, you've got a pretty sure idea that's where you are. So we're wasting our high priority slot here with irrelevant information. If we continue our Z scan down, what's the next thing they're going to encounter? Well, it's Emma Stone. I think this is where Warren Beatty starts to look uncomfortable, because he's not expecting an actress's name at this point. He's confused by that. When he hands it over to Faye Dunaway, what does she find? Well, she's looking for the name of a film. La La Land is the name of the film that you come to first on that Z scan, and that's what she reads out. Best Actress is at the very, very bottom of the card. If we think about what I just said about the idea of search satisfaction, you stop searching after the first thing that satisfies your needs. She might not ever have read any further than La La Land. Even if she did, that strong line across it actually changes the way that people read. A lot of people won't read below that line. I've tested that experimentally. So we've got 9 words written on this card, and it's managed to be laid out in a way that is the exact opposite of what we want it to be for safety critical function. So even something as simple as this card contributed to the accident that we've just witnessed. If we extend a little bit about the notion of what psychology means for our workers, I'm just picking out a couple of things that interest me, but production pressure is one of them. Production pressure is something that I've encountered in a lot of incidents that I've investigated. I first encountered it, the concept of it, reading through the Rogers Commission report into the Challenger shuttle disaster. That was a NASA spacecraft that was destroyed on launch in 1986. I just remember it happened when I was a child. It was very interesting. What production pressure really says is that we are all under pressure to make sure that the show must go on. In my context, my clinical background is an anaesthetist. So I turn up to do my operating list in the morning. I'm expected to get through that list, get all the operations done by the end of the day. Now, most obviously, production pressure is something that can be put on us externally. So managers might put it on us by saying, well, waiting lists are really bad at the moment, we need to get it done. Budgets are really tight, we have to do more with less. But we also put production pressure on ourselves, probably more than management does. That's just as simple as saying, well, I've got a sports club event after work this evening, I have to finish on time. I've got to pick up the kids after school, I can't be late. So we do this to ourselves. And what it does is it forces you to keep the system moving, even when you recognize that there might be a problem with it. Now, if we think about that in terms of the event that we've just witnessed, Warren Beatty's body language said that he was not comfortable. He was not certain he was doing the right thing, but he was not able to stop it. And I think production pressure may well have been part of that. When you look at the event in total, it took everybody a long time to respond to that. And you might have noticed in the video that it wasn't actually officials of the Oscars that corrected the mistake. It was the people who'd been awarded the wrong Oscar. And this is where something called bystander effects come in. I find bystander effect very interesting. It was first described after reporting around a murder in New York in the mid-1960s. The reporting of the original event there probably is apocryphal, but the way it's described was a lot of people witnessed an abusive man in a fight with his partner over the course of many hours over an evening. Everybody assumed that someone else had called the police, but nobody did because they thought someone else had. And the poor lady was found dead the following morning. Regardless of the accuracy of that original report, it was followed up by Darlene Latan, two psychologists who did a series of experiments, and the most famous one is the smoke-filled room. It's really interesting. There are videos of it on YouTube if you're interested. But essentially what they did was they recruited undergraduates, brought them into an office, handed them a form, and directed them to a room to fill out the form. Now, the recruits thought that the experiment started after they'd filled out this form. It didn't. It was happening while they were in that room, because they pumped smoke into it to make it seem like the room was on fire. People who were directed into the room and were sitting by themselves would respond almost immediately. And the vast majority of them would seek help very quickly. But they put some of the participants in a room with stooges, and those stooges had been told not to react. And those undergraduates filling out those forms would sit in that room for anything up to about 20 minutes, coughing and waving smoke away from their face and not seeking help. Now, it might seem a little hard to believe, but it's robust and it's a repeatable phenomenon, and it happens because we're social animals. If we're put in a situation where the response demanded of us is somewhat ambiguous, we look to those around us for the cues about how urgently we need to respond ourselves. So if we look around us and we see people who are not panicking and not looking stressed, well, we don't feel panicked and we don't feel stressed. And to be able to respond, you've got to recognize that there is an incident that requires a response, that you have the skills and that you're empowered to be able to do that. And if any one of those links in the chain break down, you will not make that response. And I think those bystander effects affected almost all of the key players in our particular incident. So I think that brings us to a question of, well, if we know that this psychology is universal, if we know that there are problems with the design of our equipment, is it fair, is it just to single out the two individuals from PwC? That's largely what the press did, but I would say probably not. And we can take it a little bit deeper than that. So this is a fishbones diagram that I created to sketch out some of the contributing factors that might have contributed to this incident. And without going into a lot of detail, they are legion. This is a simple event that unfolded over the scope of about 8 or 9 minutes. And there are any number of systemic features that contributed to it. And there's a really a nice quote from a designer actually called Don Norman, that if you change the people without changing the system, you will keep having the same problems. So I'm not going to go into a huge amount of detail. I just want you to see how many contributing factors were to this. And this is not exhaustive. So if we go back to that question of, was it fair? Was it just to single them out? Nope, I would say no, definitely it is not. And that's important to us as investigators and people who might need to respond to these sorts of incidents, because it's not just to single them out, but more importantly, it does nothing to correct the underlying factors that are going to put the next team in a risky position. Whereas if we do understand that work is done, we do understand why these people made the wrong choice, well, now we can change something that will empower the next team to act in a different way. And that's the power that human factors analysis can bring to it. Now, what the Oscars actually did with this, I personally think was the exact opposite of what they should have done. My response to it would say, if I've got two sets of cards, I want to delete one of those sets. I want to have a single briefcase with one authoritative set of everything. And then there's no possibility of the next team making a mistake because there's only one card that can possibly be available at any one moment in time. What the Oscars actually did was they had a third briefcase and they put that in the production booth. And what they expect to happen is that the producer will now monitor the awards being given out on stage with their independent set. I have a few issues with that because I think that system will enable you to make a faster diagnosis that they've had a problem, but it won't do anything to prevent the problem from happening in the first place. And again, that brings us back to, you've got to understand the system, you've got to understand psychology to enable yourself to make a robust intervention. That's a very brief overview, and there's a lot of other things, a lot of other human factors issues we might choose to draw out from it, but I appreciate time is a little bit short, and I'm quite keen to give you guys a chance to ask questions. So I think we've maybe got 3 or so minutes if anyone has any questions just now, and obviously I'd be happy to talk more when we have our Q&A session at the end. Thank you very much for your attention, everybody.
Goodness me, wasn't that brilliant, everybody?
Yeah.
That
Yeah.
was fantastic. I tell you what, I watched that Oscars thing. I've never looked at it in the kind of forensic, clear detail that you brought to that, Paul, and applied it to how we go about critical incident investigation. I thought that was absolutely box office. One of the very best I've ever heard, I think. Thank you very much indeed.
Thank you.
Great question, anybody? I don't know. There can't be questions. It was so perfect. But there we are. Anybody got any questions? You see, you're master of the universe at that point, you know.
Could I have that in writing for my next appraisal?
Yeah. Don't you worry about your next appraisal. The world will spread. That was awesome. Well, look, we'll welcome you back, Paul, later for the discussion when we all get our heads together and so on. Right now, is Colette ready? Are you ready, Colette? I mean, it's one of those things of follow that. I do understand that perfectly well. But with your Ducati Monster motorcycle head on, I've got no doubt you can speed forth and impress everybody. So everybody, this is Colette Laws Chapman. Colette is going to talk. I'm really interested in this. This is going to be patient safety through the lens of transformative simulation. Really looking forward to this. Let's find out how we go in terms of simulating success. We're looking forward to this. Colette, I'm going to hand straight over to you. Thank you.
So hopefully you can see my full slides. Yeah,
we can. Thank you.
So hopefully this connects both Cindy and Paul's talks together. But transformative simulation is a relatively new term on the block, and I'm going to hopefully explain that and actually make it practical for working in health and care settings. So transformative simulation is a principle-driven framework, and the idea is the principles of sharing and empowering, but giving people the power to understand, a little bit like Paul has just shared, how to understand that Warren Beatty moment, understanding what we do in everyday practice, as well as some of the stuff that Cindy was talking about, very much investigating error, be it small error or something much larger. And transformative simulation is about being inclusive, about identifying everyone's perspective, appreciating everyone's skills, and respecting and valuing everybody's knowledge, whatever they bring to the table within the patient journey. And when I say patient, I mean client, service user, etc. It's about being reciprocal, and it's building, and more importantly, maintaining our relationship. So it's a framework now that hopefully pulls together a lot of what we've already been talking about it. So just to give you a little bit of the history, we're trying to rethink what healthcare simulation is in terms of its purpose. It's been used for educational techniques for many years, but back in 2004, really important person in the simulation world, David Gabber, who's an anaesthetist, identified that it is a technique. It's not the technology, it's not about the mannequins, but it's about how we can guide through the real situations or replicate real situations so that we can work out those interactions. So much like Paul has shown us, really. And we're moving away from it being just used in education, far more to us thinking about it being as a methodology for assessment or a way of integrating patient safety, exploring some of that safety 1 and safety 2 that Cindy alluded to. So this is the working definition, that it is about a tool to transform health and care, so across the divide of where our patients are, through collective understanding, gaining insight and learning. And that's, the underpinning perspective of PSIRF. So my colleagues, Sharon Weldon and others who are named here, are professors and practitioners within the world of simulation, but they did this piece of work up to 2023. The graph is a bit odd. It's just that they stopped collecting data at that point, but they tried to help us gain knowledge, to help us articulate what it is and what we mean. And they actually identified 68 different terms to describe those of us that are using simulation outside of education. And so they came up with 7 I's. So just to give you that situation. So simulation can be around innovation, where we want to innovate and put something new in, or test something new, or design something new. About improvement, intervention, involvement, identification, inclusion and influence. And you might all ask, why bother? Well, it's because we're trying to get the data, we're trying to extrapolate from the literature, because colleagues around the world are doing this. But if we don't all have some sort of common language, it makes it very, very hard for us to work through. And as a set of colleagues, I'm now working with them, and we've come up with another graph, which is really trying to help explain, well, what is innovation? Is it helping people think outside the box so we can do something different, to reflect on, are we working in an outmoded way, or is there something that we can just turn and tweak to do differently? We're always doing things for improvement, but is it about, can we make that better? The one I prefer to be in is intervention, where we can find out what's working, but also what's affecting us. So just like Paul's thing, what was affecting how that all worked? 3 sets of envelopes very clearly was one of those issues, and we need to sort of work on interventions to change how we're working. And then the others I won't go through, so I've got some examples to show you all. This slide is very busy, and I apologize, but I will just pull out a few things, because many people are used to using simulation for educational purposes for our undergraduates and our staff in practice, where we're setting learning outcomes and we use recreate, whether it's with actors, mannequins, whether it's virtual reality, or even using AI and other technologies now, to try and create some realism. And there's some patient staff participation for the purposes of learning, and we evaluate that. And it's about an individual learning or a team learning, as opposed to thinking about patient safety. And transformative sim can be used for a number of things under those broad headings. So there's not necessarily any objectives. We want to be curious. So we want, just like Cindy was saying with the PSIRF framework and the MDT review, after action review, we need to be curious. We need to be open and try and explore from a lens of the system, the way we interact with a piece of equipment, the way we apply technology in different contextual settings. And we try and really open up our mind to how we're working, to see what we're working well and keep reinforcing that. But more importantly, if there's areas where we can improve, then to change that. So putting it into practice, it's very much a cyclical thing. We're moving away from being reactive and bureaucratic. And I say moving away because although we've had the date of PSIRF, we still do have historical challenges and the fear that there's going to be blame until you get defensive behaviour. We're moving to this shared ownership. Safety is everybody's business. And we're also moving not just to reacting to something, but proactively utilising simulation-based practice, which I'll come on to a little bit more in a minute. Oh, and very much, as I think Cindy mentioned, but it's supporting staff and it's supporting everyone involved in an event, especially if we're using it to replicate an event. But This is the SEEPS framework. I won't go through it. Cindy's already mentioned it, but the headings are really important. We're not just thinking about the individuals, we're thinking about how they have to interact with the tasks that they're given, the workload that they have, the different environments that they could be moving within, the culture, the external environment within an organisation, or within the country itself. And we're trying to look at system performance and human performance, and really human well-being, and that's for staff, students, patients, and everyone involved, really. So I feel like, I don't know if some of you remember the Martini adverts of many years ago. I can't remember it's any time, any place, anywhere. Sorry, but this is what reminded me of it. Simulation with transformative sim is anytime, anywhere, and anyone. It is not about clinical staff, it's about everybody. So we should be involving, or we have simulation purely for management teams, for the executive board, for the housekeeping teams, or where it's appropriate, everybody together. So that little list could be really, much longer, but it's patient safety for everybody, human factor skills, we all have them, we could all improve them, and it's thinking about our skills together. The essential thing that we have to adopt these principles and then role model them, for me, is about being inclusive. So I could go in and be bussed into some area and help design something, but if I don't design it with the team, if I don't build trust with the team and we co-create what we're planning to do, then there'll be no real change. We might run a really great sim, we might find out some latent threats, but they'll just say, oh, Colette suggested we make this change, and that's not going to carry things through. So inclusion is vital. Encouraging everyone to reflect, not just on sort of work as prescribed and reflecting on, well, this is what we meant to do, but I think that's the difference with transformative simulation. It can bring in, reflect on how you imagine it to be in the future, using visual replay. So sometimes we use 360 camera footage, but so we can all reflect on the areas and have accuracy with that, to look at how things are actually going, so that we can maybe make a tweak or a change that will improve everything for the patient flow, and for the staff. Very important to think about risk. Simulation has its risks, not only in terms of psychological safety, where people feel that they're being observed and feel maybe threatened, and that could affect performance, but also, it is about what do we do with the data, and how do we share it. So corporate risk, and also physical risk. You run a real scenario, you're dealing with real equipment, and you need to think about that. And then demonstrating learning values, empowering staff, students, everybody, as I said. And then the last thing is essential. It's not a one-off. None of this is a one-off. So transformative simulation should be happening on a repeat process. The frequency is variable. So I won't go through this. This is my assessing simulation risk tool that I do, linking to what I think, okay, this is what we want to do, what are the hazards, what are the controls right now, what can we do to minimize them, and who's responsible, basically, as well, because it can cause hazards. And psychological safety, again, is really important. So people need to feel that they can be heard, valued, and respected, that we ask them to be have confidentiality with each other, ask them to wear a curious hat, and be collaborative. And we try to say that, we're all capable, able, intelligent people, but and we come to do our best. That's what Cindy was saying. We come to work to do our absolute best, but we make mistakes, and often that's because of the system. So those things are really important to set. And forgive me, this is an early graph that I'm trying to pull together to try and say what we do, or what I and the simulation team do with our colleagues in different departments. And so fundamentally, it's about what's our purpose. We know we're here to explore healthcare. It could be the workplace environment, it could be pathways, it could be human factor skills, as Paul mentioned, it could be about looking at performance variation. It could be about culture, it could be about relationships. So those, and they're all interlinked. That's why this graph, I've got a really nice infographics for this, but they're all linked. And then we have to identify our 7 I's. And the idea is you then choose, are we doing something retrospective? Is it going to be case-based, based on reality? So we could be reenacting an actual event that's happened that someone has reported on an incident report. It could be that we reenact it very quickly in the moment as part of a swarm huddle. And it could be that we do things much slower and plan it. And that can be very low cost with Lego pieces of paper, with mannequins and actors, or it can be just a discussion. And then the same applies for prospective, which is my favourite, my preference, but it's quite hard to find the time to always do it. But looking at our routine every day. If we'd have, well, the Oscars aren't routine every day, they only happen once a year, but looking at the routine events, looking at how what are the systems, where do the envelopes go, who do we get to say what to where and how and why, and we use a number of tools, and they're quality improvement tools, things we all know about, human factor tools. Cindy mentioned Stephen Shorrock's proxies of work, the variances. So that's all the stuff that translational simulation does or can do. And now I'm going to show you with a few images that I've had approval to share with you of some of the work we've done over the last couple of years. So in terms of real designs, I was asked to come into an area with our team and help actually train the staff to work in this newly built environment, a high dependency unit, so HCU high dependency unit. And we knew that we would find what we call potential latent threats, so things that are there that could go wrong. And we were asked, could we look at it, this human factors lens of what should be placed where, what's missing? So I haven't fully kitted it out yet. It's just got the lovely, expensive pedestals of sockets and alarm bells, etc. And these are a few of the things that we identified as latent threats. Because they had all the money to make them beautiful and very high tech, but they were still using the same trolleys and beds and things that were in the old unit. So the old had to fit with the new. And one of the real latent threat for us was, they call it a stack. It's this thing with the oxygen cylinders on the end of the bed, and where it worked very well in this picture in the main high dependency. But if you were unfortunately the nurse and the team working in the side room caring for a patient, then you couldn't put the stack on until you left that room, and the stack is there to allow you to have a safe transfer. So a really beautiful environment, but it wasn't fit for purpose. And we wouldn't have done that if we wouldn't have known that until a real emergency or a real transfer. And a lovely new environment. They've got, I never knew you could do this, but you can have double hinges where the doors on toilets can open in and out, which is, as a nurse, is really brilliant when someone's got trapped behind a door. But again, we were testing that, and unbeknown to us, we had a brilliant door, but we couldn't open it because we didn't have the key to open it. So if that had been a real patient, that would have meant lengthy delays. And then fundamentally, I suppose the biggest one that's a challenge for us is identifying these latent threats. Lovely new design, someone in procurement somewhere thought it was a good idea, but we identified, the nurse was running through a scenario, 2 nurses at the bedside, and they wanted to call for extra help. Suddenly they found they've got a blue button. And they looked, and on the other side of the bed there was a red button, and of course that stopped them in their tracks. They hesitated. It's natural, you're not used to that. In the UK, we only ever use red buttons, but in procurement someone had thought this was a good idea, but so we didn't have the right people. So if we'd have done transformative simulation in its true essential thing, we would have identified that way before they'd been put in place. And here's some of the lovely staff actually testing protocols that they know routinely. So this is difficult airway management situation, and they're testing the protocol they have to improve their readiness. And then actually what we weren't thinking of this, but very simple things. I don't know if you can see in the picture just at the end of the bed, that's where the gloves are. So it'd been lovely in design, but someone had forgotten the little things of where do the gloves go for easy access. And as I said, the which button. And to have observers was really fascinating, but there's something about preparing them so that they're not judging. This lovely gentleman in the photo was doing an absolutely great job. He's fully trained, highly competent, but in a new environment he couldn't function because things weren't in the place that he needed them to. So as I said, if we'd have been involved, or we could have done the design early, which is one of the transformative things, then maybe, just maybe, we wouldn't have hit these quite significant snags at times, and we might save some money and time. So it's so important, and it's so basic, but it is about thinking about who do you involve. So for us, this patient transfer could mean everybody: family representatives, the architects, the project manager, the budget holders, all the clinical staff, housekeeping, reception. They need to be involved, but it doesn't have to be get everybody there. It could be on MS Teams. If we had the technology, and I know that it's out there in the world of commercial world, not necessarily in the NHS, but you could use something on the computer. You can definitely do, and I've done a lot of tabletop design with Lego. Lego is our friend. Lego people and a map, and you move things round and just redesign it. So something very simple, and then move to a real space and what we call a cardboard mock-up. Big pieces of cardboard that represent the sides of a wall, etc. And then you move to the real stage build. And before you move and say, yes, that's fine, you should test it, retest it with the people that are using it and sign it off before you get to real-time testing. And as an example, another example, lots of inclusion, but actually not the right people in the room at the right time. Lots of tall people were testing the new scrubbing up area in a theatre, but the smaller people couldn't reach the shelf, and in another area they couldn't reach the call bells because an architect had thought it would be really cool to have them high up out of the way, not the reality of someone who's only 5 foot. So this is silly little things. That's what transformative simulation, I shouldn't use the word silly, is so important. It could really help us. Most importantly, everyone's worried about the sign-offs. So this is a new area. Everyone was focused on the infection prevention issues, but they forgot thinking about the layout, and all these cupboards open outwards, and you try and open the cupboard, that nurse had to move to get to the cupboard, they had to twist and turn to get to the emergency kit. So it looks beautiful, it's been designed by children for children, but it didn't quite work for the practitioners as well. So one of the Myron, he's done a lot of work on change leadership. It's all about engaging people. Very simple. People own what they help create. So if they're involved from the start, and that can be a design, but also that could be, it's not just physical design, it could be about a protocol, or it could be about the layout of a redesign of the layout of the reception area. But the intention is the more you connect your staff, so Myron's maxim is to connect the staff, engage them with the change, and they'll feel empowered to not only own it, but to monitor it and improve it again and again. So just in terms of time, I'll skip that one. This was one where we used innovation, so high consequence infectious diseases, moving a patient from our ambulance ramp outside the hospital, going through a CT scan and up to ITU, and it was a 7-hour simulation. It was a long day, but we broke it down in sections so that it didn't waste people's time, and we took each section and planned that route, simulated it all way before COVID. So this is a few years ago now, and it meant that when COVID happened and we had these very sick patients coming in, we had a very safe plan already in place. And the use of technology, 360 cameras, I advocate them. I don't know who the company is, but they are brilliant because they watch it from everybody's lens, and it means that we can all be involved in analysing it. So we keep the people safe who are involved, we debrief them, but we can let the managers and other people, procurement and architects, watch it from afar and get involved that way. You have to debrief. Debrief takes a skill. I prefer now, I've moved my thinking a lot to using after action review, 4 simple questions of what's supposed to happen, what happened, why was there a difference, and analyse that. You do have to be mindful that you might have some biases yourself, so you have to put those to one piece, and you do have to, as I said, be fairly experienced to manage, because this is emotional, it's real life. If you're replicating real case scenarios, it's really important that you have expertise there to support the staff. And and you can use other methods that I've signposted to there. And I think Paul mentioned it, I can't remember who, but it's all about writing it up, maybe Cindy, the data. So we have a simple tool that I'm actually still trying to simplify again, but infographics are great. This is our early write-up in sections from the SEEPS model. And then we put it into infographics for the staff for a quick and easy read, more detailed reports for management teams and the board. And I suppose it's an exciting way of working, bringing simulation expertise into the world of quality and assurance and focusing on patient safety. But it does take time, and then a bit more probably. You can do it on a budget of no budget, because I've done it with absolutely nothing, or you can spend money. That's cool, and actors cost money, but they're very real to life. And I just urge everybody, if you want to have a go, don't be afraid, but it's inclusive. Bring your quality assurance people involved, as well as patient safety leads and the clinical staff. And it's important you have a data management plan. So that's me. I'm just going to let you scan that if you're interested in being involved in a special interest group that's a UK-based special interest group looking at transformative simulation and how we make the methodology available to all. So you just scan that, that will give you the email. But if not, it's sigs@aspi.org.uk. And I hope I did that in a reasonable time.
Colette, not only did you do it in a reasonable time, but you followed Paul successfully. Which
Well,
I think
can't
is
stop
extraordinary. Bravo you, well done indeed. We've got a couple of minutes before we were due to start the round table, so would anybody like to ask Colette any immediate clarification questions or observations? No, grand. Okay. Well, I found some of that very helpful. I found all of it very helpful, actually. I've made loads of notes as Colette's gone along, and Paul and Cindy. I mean, look, I've filled a whole piece of paper here, which is rather unlike me. So thank you all. Let's go straight. Charlotte, if you don't mind, can we get all of the presenters with me now? And we'll let the audience remaining consider if they'd like to ask some questions. Whilst people are making those considerations, I'm going to throw in the big one, and I do this with a very positive mindset. If I place myself in the mind and body of a member of staff or a patient, well, we know through my mailbag that I get every week that people are really frightened of the environment in which they are obliged to work, from the perspective of being found to have made an error, caused an accident, whatever else it might be. You know, the consequences for them of doing so, whether that be from a professional perspective or from an operational perspective, can be very profound. And I don't think there's any I'm kind of with Cindy, who said I don't think anybody really comes to work deliberately wanting to do a bad job, or the numbers involved are incalculably small, basically. So how do we help those people who come to work with a good heart to do their very best embrace this new approach to what I'll refer to in an amateur manner as quality improvement, when manifestly there is complication going on here? There are steps, there are acronyms, there are lists, there are process maps. I mean, crikey, to an independent observer, this is not easy to remember or to embrace or to get enthusiastic about because of that complexity. How do we make this so that we have 130,000 people, sorry, 1.3 million people across the NHS and all the patients that they serve thinking, great goodness gracious, at last, fantastic, something we can embrace and work with? I don't mind who starts that one off. I have a funny feeling that Paul might have the first bit here, because he described that process of Oscars and so on. What do you think, Paul? You know, you came up with really simple graphs and illustrations around how that can go. How do we make, some of Cindy's and Colette's stuff more accessible, more memorable, and more positively enthusiastic?
I think a lot of it starts with the individual interactions between people in the workplace. Something I work a lot to do is to talk about mistakes that I've made. And that might be with trainees who are with me on a one-to-one basis. It might be in presentations and formats like this. But a lot of it is normalizing the experience of having made errors or being involved with critical incidents, because it's going to happen to every single one of us. It's not possible to engineer errors out of the system. What we need to focus on is making the system robust to be safe when those errors actually happen. So making it okay for people to have that conversation serves two functions. One of them is it makes it more psychologically safe, because you appreciate you're not the only one who this has ever happened to. And it also gives us an opportunity to share learning about it. And by sharing learning, you can then role model those positive behaviours. So when me as a relatively senior clinician, I'm a directorate's governance lead, can say this safely, hopefully that empowers other people to speak about it in a safe way as well. And that carries through into things like swarm huddles, for example, is bringing people together to share those experiences in the immediate aftermath so that they recognise they're not the only person who feels that way. I mean, they recognise that their colleagues feel the same way. Now you can start to build that resilience into it. So I think it starts right at the coalface, if you like.
And we normalise the idea of fallibility.
Exactly that.
A better word.
Exactly that.
I like that. Cindy, would you like to comment? It seems to be a little while since you spoke, but I'll go to Cindy next, then I'll come to Colette. Thank you.
I mean, I think there's so many ways that we need to work on this. So, and one way that's very important is actually through well-being. So we know that safety culture metrics decrease if staff feel burnt out, if the rotas are empty, if their workloads are excessive. So in order to make immediately, if you improve staff well-being, you improve patient outcomes. So I think that it's a really integral part of how we make work better for colleagues. So I think that's one. Having conversations. I mean, education. You did ask me actually, John. It's complicated. How have you communicated this to colleagues? How have you got them on board? We've done a massive education campaign. It is, I suppose you're right, there are acronyms, but it's a language. And we start with our patient safety leads. We have ways of cascading through the organisation. And I think it is just going to take time. And a willingness of our leaders, so that the leadership qualities that you need here. You need colleagues to be talking about safety the way that Paul's doing. It's not just going on a course. He then walks the walk, and we've all got to do that a bit. So I think there's lots of different ways that we can make it something that's tangible to colleagues across the organisation.
Thank you, Cindy. Colette, to you, same question.
Thank you. Well, I think it's definitely about role modelling, and it's about empowering others, giving them those skills so that they can do that themselves as well. So one of the things that we did really well during the pandemic was we had debriefs every day, that reflection every day, so that we could be agile, and we supported one another. We learnt what was going well. We recognised and articulated safely that actually that isn't working so well, so we can change it. And I would like to bring some of that back. Short, supportive, reflective discussions. And I think that take the jargon out of it and just have a reflective discussion. There are multiple models for debriefing, as an example. It's what I spend my life in, and it's ridiculous, but it does need a little bit of skill. But I think that's it. And adding on to that, we need people to understand that we have to follow as well as lead. We don't need all leaders, we all need to follow. But if we can feel safe to discuss and to chat about the challenges, then we'll hopefully create that culture that surfaces as something that's challenging us.
I suppose the big issue during lockdown you were obliged to have those daily debriefs, really, and you were empowered to make immediate improvements, changes, and I suppose that's one of the things that's gone now, is we don't have that necessity for immediacy, and we've perhaps lost the empowerment to act as well. We've gone back to a traditional hierarchical structure rather than being a very flattened, let's just do what needs to be done kind of an environment, and I rather crave that. I'd love that to come back. I know that a lot of our members would like that to come back. It's that feeling of empowerment that, if anything, has been rather lost, or has gone missing, let's call it that way. We've got a couple of comments from people. So Carlos has said, unfortunately, datix has now become a threat to other members of staff rather than being about learning. And I wonder if anybody might like to comment on that observation from Carlos. Yeah, go ahead, Paul. Thank you.
Only that I recognise that does happen. I have seen it become almost weaponized, in a sense of I'm going to tell the teacher on you is almost the way that it's handled. It shouldn't be that way, though. The problem with it is that it closes down conversation, and it means that people aren't able to share safely the incidents they've been involved with. So some of that learning is hidden. It creates a culture of omerta. And I do work with the Prison and Probation Service in their investigation pathways. And this is very much the place where they are. And you can see that it's corrosive to the safety agenda. So I work very hard to try and role model, but also to check people that are using it that way, to explain to them that that's not what it's for and that it's not helpful to do it that way. Because if the ultimate objective is to make the system safer, blame is the antithesis of that.
Are we helped in any of this? Oh, I'm so sorry, Donna, you've got your hand up, so I'm going to come to you for your question. Thank you. Would you like me to unmute you, Donna?
This is for Cindy. I've been thinking about what you said because I found yours quite interesting in quite a few ways. The question is, it's all right making it fairly simple for colleagues, and I'm all for that because there is quite a lot of information to try and absorb. But making it simple for patients, and you said trying to get patients' input. I've worked in 4 hospitals. The one I enjoyed working in the most, and it's something quite simple, but they seem to have got rid of it for some reason, is colour coding the floor. One of the hospitals I worked at, for patients, especially if they were visually impaired, but could still see, but they weren't blind, they actually put colour on the floor to the various departments. So instead of having to ask people, which is what you have to do at the moment, I've done it here. If you don't know where to go, there was a big chart on the wall. Oh yes, I want to go to this one. Follow the pattern all the way down, and it led you straight to the department that you needed to go to. And the other thing is lifts. I have a friend who's visually impaired. She thinks the fact that you could hear what it says is lovely. First floor, second, third floor, but the buttons are too flat. So she can't feel which is floor 1, 2, or 3, or 4. So it's empowering patients. If you talk to patients, especially patients with disabilities, sometimes you think of the big picture with them, but like you said, Colette said, in the little things, it's the little things that catch out. So I would like to see, yes, make it simple for us, please, because there's a lot of information. But if we want to get patients involved with it, you've got to think of try and make it even simpler so the patient can look at it and say, oh yes, I know they could do this.
Got you. Thank you, Donna. Cindy, would you like to respond?
Yeah, thank you, Donna. So, I mean, that real involvement of patient carers and family, really doing it well, we're on a journey. Okay, we have done some things through the framework and the strategy. So we do have patient safety partners. These are volunteers that give us 10 hours a month. They sit on our patient safety meetings and they challenge. So I think we are hearing that, and it's really important. So that's one thing. And I think the framework itself, we had two colleagues who spoke to our execs about the experience of involving patients through these investigations. And it is a different type of experience because, as I said, it's not just that report at the end. It's, well, what happened to you? What's your perspective of workers done in this situation? What support would you like to see? So, I think we are trying. But to your other point with regards to disability, we do have a patient and public engagement team. This is something that we talk about a lot, and not just that, having the the Wi-Fi connectivity for sign language, which we do on iPads increasingly now for our deaf patients, but we don't have the connectivity. So it's like you said, it's those small things. And I think as an organization, we're a big organization, so thinking of the small things sometimes is something that we don't often do that well, but we're on a journey. But thank you for highlighting those things.
Well,
Definitely something I'll take back.
I know it's going to take time. It's like anything else. Rome was not built in a day, and it's going to take brick by brick by brick, and a lot of rethinking and a lot of discussion. But if that's all I really wanted to point out,
Thank you, Donna.
look at the big picture, but
small stuff counts. Small stuff is the big stuff, Donna. 100%. And I'm kind of with you as well, Donna. I hear the Rome wasn't built in a day thing, and people kind of, in my experience, they rather use that as an excuse to take way longer than is really necessary if there was a sense of urgency. So I'm kind of a bit of an advocate for get on with it. I hate the idea that we set in stone kind of length of times that things should take. Do away with that, would be my plea. Just ask people to do it as fast as they reasonably can, in the way that we did during COVID, etc. We haven't got any other immediate questions, so let me ask one, if I may. Is inspection, labeling and targeting of labels, desired labels like outstanding, is that helpful to fallibility disclosure? In other words, if we're serious about QI, should we reject the notion of our organisation or teams being subject to an external, publicly disclosed inspection regime? Go for it, Cindy, and then I'll come to Paul.
I'll be very brief because I can see we haven't got much time. So I think that we've got to be transparent, and so I do agree with that. And the way the CQC does its inspections is that there is no organisation that has been rated outstanding that has not embedded an improvement system. It is absolutely integral to the way that they inspect and the ratings they then give.
Thank you. But equally, I've come across NHS organisations who set a target of achieving outstanding, and they don't get none of these people that I'm about to describe actually then get an outstanding rating, but they set a target of outstanding, and the effect that has is it stamps down on any admission of fallibility. And that's heartbreaking to me, that we've got into that mindset, basically. Paul, would you like to comment, please?
I was only going to say that I think some independent observation of practice, be it organisation or individual level, is important, because we are all vulnerable to a thing called normalisation of deviance, which is where practice evolves over time, where certain small changes might be tolerated, that becomes normalised for the next generation that comes in, and so on, and practice gradually migrates away from what was originally considered acceptable. That happens in all organisations. And a fresh pair of eyes can help to recognise when that's happened. But I think the key thing that links what both you and Cindy have just said is that the metrics that you're assessed against have to be realistic drivers of the behaviour that you want, because it's very easy for targets to be counterproductive in that way.
Thank you, Paul. All right, well, Colette, I'm going to give you 30 seconds to respond, Colette, if you'd like to. Are you good? I
mean, I think we need some kind of benchmarking, but it's got to be something that's meaningful to people and understand. People need to understand it at every level, including our patients. That's all.
And I guess provokes the right behaviours as well from people more than anything else. Good. Well, look, I've found that thoroughly fascinating. I hope you have as well, whether you're watching it live or whether you're watching it via catch up. But we have recorded this, just to be clear. So my only duty is to say a very heartfelt thank you to Cindy and to Paul and to Colette for giving up their time. I think there's some really box office stuff there. I think that Greater London is in good hands if it's in the hands of Guy's and St Thomas's with your fabulous approach to this business of improvement through simulation and such like. So thank you for doing such a wonderful demonstration of what you're up to and how you're up to it. And I'll say no more, otherwise I'll rabbit on and people will get very bored very quickly. So thank you all once again, and we look forward to another showcase session from GSTT in the near future. Thanks very much, everybody. Wishing you a wonderful week. Bye bye.